Okay, here's the final case. Liz is a woman in her late 40s with whom I've worked for more than 18 years. She suffers from irritable bowel syndrome and is given to acts of impulsive gorging. She entered treatment complaining of a lack of fulfillment in a variety of areas in her life. She generally complains of being depressed, isolated, and engages in intense self-attack. In addition, she feels threatened by writer's block, which puts her at risk in her work. Liz frequently uses body language to express herself, referring to pains in her head, tingling in her neck, and eating binges, causing stomach pain. Many years ago, she reported having a polluted pouch full of disgusting junk in her mouth, a symptom that seemed like a metaphor for holding back what she deems unthinkable. In general, I find myself having the feelings that she does not feel. Liz nullifies feelings and experiences, fluctuating between severe bouts of depression and occasional episodes of uncontrolled eating to the point of extreme pain and self-loathing. She reports engaging in severe verbal attacks on herself, where she'll report having said, "I hate you, you should be dead." These also occur in the room, but are not expressed with full feeling. At these times, she evokes a weighted down, dead feeling in me, as though she is buried deep inside herself and we are both wearing cement shoes. She remains cut off from knowing what she wants. In the treatment, she describes that things in her life are falling apart and unraveling, yet conveys no apparent response or natural instinct to intervene on her own behalf. I tend to have the experience of free falling, of a dangerous state without protection. She also maintains great distance from knowing her dependency wishes and longings for intimacy with the analyst. These have been revealed in dreams and coincide with reports of gorging action. When she reports deep bouts of debilitating depression, I feel what appears to be tremendous underlying hurt and longing for merger, alongside a suppressed torrent of rage. She tries to suppress volcanic rage that is integrally connected with her infantile longings to be cared for in an atmosphere of safety and bliss. Liz keeps thoughts, feelings, and longings outside of consciousness, mainly through ejection by action, a counterpart of somatic acting in. On many occasions, I feel the intensity and danger while she seems to be oblivious or to feel nothing. It is quite provocative, and I feel like screaming, "Look out! Don't you see what you're doing?" It leaves me feeling helpless and trapped. There is an immediate ejection of or acting on aggressive impulses. As noted above, she engages in brutal verbal self-attack along with an impulsive action that causes harm to her body, such as binge eating until feeling sick, episodes of excessive drinking, etc. When the patient reports intense self-attack or deep depression, I feel that she's stuck in sludge, in a heavy state of immobility. Liz's dreams frequently convey intense aggression and hopelessness. On one occasion, she reported, "I was driving a car with no brakes and I woke up terrified." This dream reflects that she is mainly driven by urges and action without access to mentation. She has no control and is at the mercy of her impulses. Liz's irritable bowel syndrome and impulsive gorging reveal the imbalance and constant struggle with the fusion of her aggressive drives and unfulfilled libidinal needs. The impulsive action of gorging serves simultaneously to erase a potential feeling and direct aggression towards herself. She literally swallows her rage and attacks herself through taking in. She's engaging in a constant attack against her dependency needs, which are always looming. In the coding analysis, reports of physical distress tended to coincide with indications of restricted thought, limited fantasizing, or of a confused state, attacks on the mind. which support the idea that her body is absorbing the feelings that couldn't be tolerated. And in the sequence analysis of somatic reports, there is a clear correlation between reports of intense self-hatred or self-attack followed by a report of physical symptoms or behavior involving physical pain. The conscious response to her longing to engulf is to eat up is disgust and self-loathing as she defends against an impulse to destroy the object. She's engaged in a constant precarious battle to keep the explosive rage buried through the impulsive action of self-attack and gorging to the point of actual pain. She can never feel comfort because any tension released through action comes back as a fierce attack against her. The onslaught of self-attack is not at the level of elaborated conscious thought, but it is an explosive barrage of self-hate that appears reflexive and uncontrollable, not mentalized. So that's the third case. And believe it or not, I'm up to the final discussion. Hey. Okay. Freud conveyed that transference is not obvious. It can't be observed, but can be deduced. And in certain somatic cases, the meaning can be far more obscure. On the concept of autistic contiguous position, Thomas Ogden expanded on D.W. Winnicott's brilliant idea of transitional space, applying it to the treatment setting. This also resonates with Andre Green's idea of thirdness, where the analytic pair generates an unconscious intersubjective construction, a new subjectivity. Ogden describes that in cases where there are severe restrictions in psychic function, the system is closed off from a mutually transforming experience, leaving no space for psychic expansion. He has described how the analyst's use of reverie, feelings, sensations, and thoughts can contribute to create analytic meaning. McDougall noted that for primitive patients to allow themselves to unfold within the transference, they have to bear the emergence of archaic instinctual impulses connected to longings and wishes that have been long buried. McDougall and others note that preverbal patients may not convey clear-cut transference meaning in object terms through the content of sessions. However, there can be meaning in the process of communicating, which expands the capacity of expression through language, providing new pathways for dealing with psychic tension. As Phyllis Meadows said in regard to preverbal patients, the transference manifestations are different from those of patients whose emotional growth continued successfully through the use of speech and who can use language to elaborate more complex defense measures to control impulse discharge. Utilizing the modern psychoanalytic approach, ego-insulating techniques of joining, mirroring, and monitoring the stimulation level facilitated the development of deep narcissistic transferences, allowing these patients to play out and project their inner states within the context of the analytic experience. The most critical element in the treatment of these cases was my use of induced and countertransference states. My primary aim with blocked off patients is to be receptive to my internal state and allow fantasies, images, physical responses, and associations into my conscious mind. In addition, I try to remain alert to potential dangers in receiving toxic inductions from the patient. There's a delicate balance between allowing oneself to be open while at the same time maintaining a vigilant, alert stance with cases that harbor a torrent of unfiltered aggression. The potential dangers to the analyst in work with somatizing patients was emphasized in a recent International Journal of Psychoanalysis issue, which published a paper written by Pierre Marty written in 1953. As noted earlier, he was a founder of the Paris School of Psychosomatics and led a movement toward viewing these states in terms of inhibitions or failures of psychic elaboration, leading to his theory of operational thinking. He has consistently asserted that the field of psychosomatics has been marginalized due to the potential narcissistic threat that it can evoke in the analyst. In the paper, the narcissistic difficulties presented to the observer by the psychosomatic problem, Marty proposed that work with severely somatizing patients could provoke various difficulties in the analyst and may induce them to reject such patients, suggesting that a primitive narcissistic state may be evoked that can bring an actual experience of danger or self-destruction to the analyst. In addition, as psychosomatics deals with the invisible and the non-schematizable functions with no spatially defined object, its obscurity confronts our tendency to seek security in the visible object. My aim is to shed light on patients who may go under the radar or who may arouse very difficult, challenging states in the analyst that can range from painful feelings of failure and ineffectiveness to potentially threatening states of regression or actual physical pain or damage. They may have a dangerous impact on the analyst and can certainly provoke us to reject them. Sitting with and tolerating and utilizing intense feeling states allowed me to continue and for the treatments to proceed over many years. It is clear how important it is to be mindful and to find opportunities to process these clinical experiences, remaining alert to possible toxic effects, and allow oneself access to the many layers and levels of experience. Thank you.